Although it is a serious brain disorder, schizophrenia is treatable. This is a time of hope for people with schizophrenia and their families. Dr. Xavier Amador is a world-renowned expert on schizophrenia and bipolar disorder. He spoke recently at the 17th annual Living with Schizophrenia in Nova Scotia 2005 conference.
What I'm going to talk about today is a problem that affects a lot of people. And I'm going to talk about how common the problem of lack of insight is into serious mental illness. And I'm going to talk about the research. I'm going to talk about things that we've actually learned over the last 10, 15 years about the nature of this problem. Why do so many people with schizophrenia, with schizoaffective disorder, with manic depression, why do so many of them not understand they're ill? And why do we, and when I say we, I mean mental health professionals and family members, get into these battles that seem to never end and get us nowhere, but estranged from the person we're trying to help. So that's where we're going today. We're ultimately going to talk about what you can do, very, very specifically, things that you can do to engage somebody in treatment who doesn't believe they need treatment, who doesn't believe they're ill. So ultimately, that's where we're headed, and frankly, that's the part I like best. But I think we need to sort of share a common knowledge base before we get to talking about how do you engage somebody. So I'm going to talk quite a bit about some research. Before I do, I want to have a feel for who I'm speaking to. I don't want to make too many assumptions. So I'm going to take a little poll of the room, and I'll raise my hand and let you know who I am too. How many of us have a family member with a serious mental illness like the ones I've just mentioned? Okay. How many of us have had or have serious mental illness? Okay, me too. How many of us have ever worked as a mental health provider or as a consumer peer specialist? Something along those lines. Wonderful. So we have all three major stakeholders in this room. People with the illness, the people who love them, and the people who are trying to help them, who are professionals. And it's only when you have all three together, I think, that anyone can really recover or do as well as they ultimately can do. Let's just start with, very briefly, how common the problem is. Who here, by the way, who here has heard me speak before? Would you raise your hand? Okay. So you can't answer this question if you've seen this picture. Who has not heard me speak? Do you know who this is a picture of? Anyone? I thought I heard somebody. Anyone want to make a guess? No? Well, of a family, it is, yeah. And I guess it's a bad question. I meant the woman in the picture. Exactly. I think you're right. She's not a movie star. It's David Letterman. She was the woman that everyone knows as David Letterman's stalker. She's the woman that had a delusion. She believed she was married to him, so she would show up in his house again and again and again, charged with trespassing, criminal trespassing. She once stole his car and drove through the Holland Tunnel in Manhattan and was pulled over by police, and she was incredulous when the police officer told her that she was in a stolen car. She's like, "What do you mean it's a stolen car? It's my husband's car." Right? You all know who David Letterman. Anyone here not know who David Letterman is? No? Okay. Was he Canadian or something? Anyway, her daughter, who's sitting on her lap, and this one right here, is that a rear projection? Anyway, her. Looking for a shadow. That's scary. I couldn't see my own shadow. It's spooky up here. Anyway, Annalisa helped me with the book that has the same title as this talk, I'm Not Sick, I Don't Need Help. And Annalisa had never, ever heard what her mother's illness was. Her mother had never gotten treatment. She was again and again brought before judges for criminal trespassing. She developed a delusion about an astronaut as well, that she was married to him, never got treatment, and ultimately she died from the illness. And in her case, it was schizoaffective disorder. What do I mean when I say that she died from the illness? Anybody? Right. It's by suicide. I don't like to say commit suicide because it sounds like knowing and voluntary decision one makes. And I think in the context of mental illness, it is very rarely a knowing and voluntary decision. So I prefer to think of it as like dying from cancer or heart disease. At any rate, Margaret Mary, like many, many people with these illnesses, never understood she was ill. No amount of pleading from family members and friends, no amount of coercion from judges ever got her to say, I'm sick and I need help. About 6 million in the U.S. people have the disorders I've been talking about. I'm going to talk mostly about today. Although much of what I'm going to say, really goes beyond these psychotic disorders, so-called psychotic disorders. But today I'm talking about schizophrenia, schizoaffective bipolar disorder with psychotic symptoms. And about 6 million in the U.S. People don't understand that they have this problem, one of these disorders, and about half don't understand that they're ill. So it's a big, big problem. And I'm going to talk a little bit in detail about some of the research, but before I do, I just want to mention another story, another family's story that hit the headlines. This is, of course, Theodore Kaczynski, who you might remember as the Unabomber. How many here never heard of the Unabomber? A few of you? Okay. He, he was the first person to ever, long before Osama bin Laden, he shut down the U.S. Air system for a day because he was sending bombs for about 20 years to various people, university professors and airlines. Ted's brother, David, and Ted's mother, Wanda, tried for many, many years to get him to understand that he was actually very ill. He has schizophrenia. And very, very smart man. He was a professor at Stanford. He had gotten a PhD in math, brilliant mathematician, Harvard trained. But unlike John Nash, you know the story from the movie A Beautiful Mind? Unlike John Nash, who had schizophrenia and was a brilliant mathematician, he never, ever understood he had an illness. And to this day, he still doesn't understand. So when he was arrested and his attorneys saw that he had confessed, essentially to himself, he had in his diary, described in great detail what he had done, they saw, especially when they saw his state. I mean, look at him on the right. When they arrested him, he had pants on that had not been changed in over a year. There was mold in the pants and tears in the pants. There was mold growing in his bed. There were piles of feces, his own feces, in his small little cabin. That's one of the reasons you may recall the defense actually took the cabin, put it on a trailer bed in Montana, and brought it to Sacramento for the court case. They wanted the jury to walk in that house. They wanted them to see this is not a brilliant, diabolical, evil mastermind. This was a very, very, very sick, disorganized, sad person with some, unfortunately, murderous delusions. So, I always hesitate to get into this story because I don't want to talk about people who have committed crime who are mentally ill, but the fact is, like anybody, whether you have a mental illness or not, you can commit a crime. In this case, it really was his psychosis that led him to it. I mean, people with mental illness are not more violent and certainly are not more criminal, if you will, than anybody else, but do unfortunately end up in the criminal justice system. At any rate, these defense attorneys were really remarkable in their desire to help him. One of the first things they did was they got him evaluated, and they explained to him, if we can tell the story of your mental illness, if we can talk about the fact that for 30 years you've been delusional, you have schizophrenia, you've been terrified, and that's why you mailed out these bombs, because you were so frightened. If we can tell that story, we believe we can save you, not from prison, you're going to prison, but we can probably save you from the death chamber. So he understood what they wanted to do, and he absolutely, adamantly refused and tried to fire them. Tried very, very hard to fire them and came very close to actually getting his attorneys fired simply because they wanted to tell the truth. They wanted to talk about his mental disorder, his mental illness, and the role it played and what had happened. His lack of insight was so severe, he was willing to die. Literally. As he put it, I would rather be executed than be portrayed as a sickie, is the way he put it, unfortunately. I'll come back and tell you what happened if you don't remember, but I was very struck, especially by the tall guy with the gray beard, Gary Sowards. I was very struck by his anxiety and his frustration with Ted. He worked very, very closely with Ted, and he tried again and again and again to convince Ted he had a problem. I mean, he would show him pictures of his cabin. He would Ted, nobody lives like this. Come on. I mean, don't you see that something's wrong? Absolutely wrong strategy to take with him. It's the kind of strategy I took with my older brother, Henry. When my brother Henry first became ill, I thought I would very kindly and compassionately point out to him all the ways in which he was clearly psychotic. And all it did was make him angry, make him stop wanting to talk to me, and make him feel very, very alone, because all I did was argue with him. And 10 years later or so, I'm having conversations with Gary, who's working with Ted Kaczynski, and I'm hearing all the same struggles. Ted understands that if we can present this, this evidence, we can probably save his life, but he won't let us do it. I don't understand why he's being so stubborn. What can I say? How can I convince him? And I was just really, really amazed and struck by how my personal experience, as well as my experience as a clinician working with people in clinical settings, was being mirrored in this case. Well, denial of illness impairs common sense judgment, right? Would you all agree with that? Yes? Okay. You're wrong. I think you're wrong anyway. Think about it. If you didn't think you were sick, who here, if you did not believe you had diabetes, you're absolutely 100% certain, you've been to the doctor, you know you don't have diabetes, would you take insulin? Raise your hand. Why isn't anyone raising their hands? Because you're not sick. What does that mean? What? Exactly. You don't have diabetes, so why would you take medicine, right? You're not sick. Why would you take medicine? If you took medicine, what would that be? Admitting you're sick? Well, actually, you could interpret it that way. If you took medicine for an illness you didn't have, it would be bad judgment, wouldn't it? Anybody here who would take insulin, for example, for an illness they know they don't have, would be a bad idea. It could hurt you. So the trick question wasn't to be funny. It was to get you to shift your thinking as we go forward in this conversation this morning. I want you to shift your thinking and put yourself in the shoes of the person who believes, they're not just saying this, they know this. I am not sick. There is nothing wrong with me. So when that person refuses treatment, what they're doing is exercising what? Common sense. Good common sense. I know that sounds backwards, but if you're living in that person's skin, if you're walking in that person's shoes, that's exactly what it is from their perspective, isn't it? So my conversation with my brother Henry, from his perspective, I was crazy. Are you out of your mind? I'm not going to take these medicines. They're going to poison me. Who's heard that? Raise your hand. Who's heard that in discussions with somebody with a serious mental illness who doesn't believe they're ill? Real high. It is poison. Look how common that is. Keep your hand up and look around the room, folks, and see what I see. Isn't that amazing? So why is there such consistency? Because people are people, and it's common sense for a human being to refuse medical treatment for an illness they don't believe they have, and to fear that it would be poisonous or hurtful to them. Well, if we're not are we dealing with denial? What I'm going to talk about is actually a lot of research indicating that we're not dealing with simple denial or defensiveness. What we're dealing with actually is a syndrome, a neuropsychological syndrome, or even a neurological syndrome called anosognosia. And this is a syndrome that was first described about 120 years ago maybe 100 years ago by a French neurologist. And it describes what happens to people after various kinds of brain injury. And the classic example is somebody who is paralyzed on one side of their body following a stroke. So imagine you're paralyzed. Anyone here ever known anybody paralyzed on one side? Okay, now imagine that person doesn't know they're paralyzed. That's what the syndrome looks like. This is somebody who is unaware of their neurological deficits. And there's lots of ways this can be manifest, lots of different ways that this can appear. And I'm going to give you some examples in a few minutes. For those who want to learn how to say it, this is not the phonetic spelling. It just helps me to remember how to say it. Anosognosia. Let's talk quickly about some research. In 1989, when I first started doing research, I was very, very interested in this problem because of my experiences with my brother. My brother was somebody who I really looked up to growing up. He's 7 years older than me. Henry taught me a lot of things in life. Our father had died when I was very young, and Henry was in many ways like a father to me. He taught me how to ride a bicycle. This young man, in many respects, took me under his wing and taught me, among other things, how to be humble and how to be self-reflective. Very, very insightful person, and he still is. So when he first became ill and went from being delusional, terrified, and terrifying, he was very frightening because he was so scared. He was getting angry, hearing voices, and then going to that first hospitalization and coming out of that hospitalization calm, not hearing voices, not believing any longer those things that terrified him, the delusions he had about my mother in particular, and that she had been taken over by the devil, and all sorts of bizarre variations on that. So he comes back and he's doing great, and within 2 days, the pills are in the garbage. And that started about 7 years of me fighting with him and arguing with him and not understanding him and thinking that he was actually being really stubborn, immature, difficult. I didn't understand that he was exercising common sense. I thought that he was being really, in many ways, childish, and that he needed to face up to the tragedy of he's sick now, and this is back in the early 80s, and back then, the prognosis you had, and it was inappropriate then, and it is today as well. The prognosis back then was, well, this is a terrible declining illness, and you're just going to get worse. It's not a pretty picture. How many heard that with a relative, right? The sad part is that in the early 80s, there actually was research that indicated that that wasn't the case. And still doctors, myself included, were learning that. We were learning the old descriptions from Kraepelin and Bleuler, which were not based on science, not based on empirical data. But anyway, that's another story which is related, and we'll touch on it. So when I started my research career, I was invested in this. This was so frustrating for me. I wanted to help my brother. There were many patients I'd worked with over the years by the time I started doing research. And I looked, and there really wasn't a lot of empirical research on insight on this problem. So I had an opportunity to do a study, really to attach an insight scale to a larger study that was going on when the DSM, the diagnostic manual, was being revised in the late 80s, early 90s. And I just want to give you some major findings from it. The first is, and we looked at about 420 or so people with various psychotic illnesses. And this is just a slide of the people with schizophrenia, 221. About 60% were moderately to severely unaware of having an illness. They didn't think anything was wrong. About 40% said, yeah, I've got a mental illness or I've got a nervous condition. They had insight, right? We found the same thing in the schizoaffective disorder group. We found the same thing in the people with bipolar disorder. We didn't find it in the people with psychotic depression, which was really weird to me. Because if this was psychosis, if this lack of insight was someone being defensive, like I thought my brother was, then why, if you had psychotic depression, wouldn't you be defended against that? Why wouldn't you also be in denial of that? And that was one of the first things that got me thinking that maybe this wasn't simply denial. We looked at awareness of signs and symptoms of mental illness, and there's just really two big take-home points I want to give you from this slide. And again, schizophrenia, bipolar, schizoaffective disorder, people in this sample had the same pattern that the people with schizophrenia had. There were a number of problems with being aware of signs and symptoms. So just look at this first bar. 40% of the people with schizophrenia were unaware that they heard voices. In other words, they knew they heard voices, but they thought they were real. They thought other people could hear them. What I'm not showing you is interesting. 60%, the other side of that bar, understood the voices weren't real. They had different ideas about what caused them, but they understood they weren't real. But what's the take-home point? There are problems with awareness of illness across even the signs and symptoms of the illness. So it's not simply people who are saying there's nothing wrong with me. They're not even noticing or are not even aware of the specific symptoms, many of the people in these studies. And there have been many since this one. That's one take-home point, but the other one is that you have people who are aware that they have mental illness or unaware they have mental illness and are aware and unaware of particular signs and symptoms. So the point being that it's not as if they're in denial of everything. They can have pockets of insight, some awareness, and that becomes important in just a moment. Now, that study was published in 94, but we finished it in 1991. Just gives you, sort of another example of the snail's pace of science getting down, trickling down to the people who need it. And by the way, once it hit the Archives of General Psychiatry, I'm sure no more than 100 people read it that first year. So, it's been trickling still 10 years later. But right after we completed that study in the early 90s, I also found this strange literature on unawareness of tardive dyskinesia. And everyone knows what that is? Movement disorder. That especially the older antipsychotics were prone to cause in a subgroup of people. So you see things like this pill rolling movement that can't be controlled, or the grimacing. So in these studies, people were asked, do you see you have a movement disorder? And the answer in this first study, that about half of the people with schizophrenia who also had the movement disorder, the answer they gave was, nothing wrong. You don't see that you can't stop your mouth from doing this? No, I've never noticed that. This study found the same rate. About half of the people with schizophrenia with the movement disorder were unaware of the movement disorder. Now, when I looked at this, I really started to wonder if this was denial. I can understand being in denial of a serious mental illness. What with the stigma, what with the fear we have about going crazy, any and all of us have that every day of our life, whether you're aware of it or not. I can understand that theory. This is denial. This is intense denial. But why would you be in denial of this? Your hand doing this? I'd be scared if I saw that. I'd want help with that, or I'd be curious about it. I can't imagine I'd be in denial of it. I'm not saying this is proof of anything, but I'm giving you a feel for how my thinking on this problem has evolved. In this particular study, and this was done later, so actually I'm out of order chronologically, but in that study and this one, and the last one, all three studies found that the people with schizophrenia who were unaware of their movement disorder were not always unaware of the schizophrenia. So we had people in these studies, that study by Trameau, who was a postdoc, I'm actually one of the authors on that, and I'll tell you about that study. We had people in that study who knew they had schizophrenia, but they were unaware of the movement disorder. So again, to me, that's not sounding like denial, right? If denial is about pushing out of awareness something that is so painful to be aware of, why would you be aware of this stigmatizing mental illness but unaware of a movement disorder? It just didn't make sense. I'm not saying denial doesn't play a role in these situations, but I am saying that we overestimated it, and I'll give you the proof in a few minutes. Well, the evidence anyway. This last study, I just want to say one more thing about it. The Karachi study, they videotaped the people in the study, and they showed them their movement disorder. And all of them developed awareness in one form or another, to varying degrees. They became aware that they had tardive dyskinesia, which kind of makes sense, right? You're showing them a video, it's kind of hard to still hold on to the idea that you're not having problems controlling your movements. But what's really striking is 2 weeks later, when they reevaluated these patients and asked them about their movement disorder, nearly every one of them said, oh no, I don't have that anymore. I had it back then when you showed me that video, but I don't have it now. Now that to me is not sounding like denial. When you break through denial, some of it may come back, but generally you learn something. You learn something very important that sticks with you. Generally. I'll just tell you a little story to illustrate that point. When I'd mentioned earlier that I've also received psychiatric treatment, and I had my first clinical depression in the early 90s and was completely, utterly, absurdly in denial about this. I had lost a lot of weight. People thought I was physically ill, and I was, if you consider depression as a physical illness. But they thought it was something else. I wanted to die. I was so depressed I was waking up crying. But I thought, I'm okay. Nothing's wrong with me. I was kind of, I could sort of point to some things that had happened in my life that were making me sad. But this had gone on for almost 6 months. And I had other signs and symptoms. Glaringly obvious. It should have been glaringly obvious to me. But I was absolutely in denial. My friend who worked next door, who worked in a depression research study, came over one day and essentially sort of, held a mirror to my face, or it was almost like showing the videotape to these patients. She said, would you answer a few questions from a questionnaire that we're working on, developing? I said, sure. And she gets 3 questions into it. I'm like, this is the Hamilton Depression Inventory. This is nothing new. She says, well, just bear with me. Just answer them, honestly. And we get through it, and we get to the end. She totals it up, and I'm smiling at this point because I know what she was doing. And she said, well, congratulations. You've met criteria for our electroconvulsive therapy study. And I got it. I got it because I was in denial. I didn't have anosognosia. This is not a neurocognitive deficit in my case. It was psychological defensiveness. My denial was so severe. At that time, I was writing a book called When Someone You Love Is Depressed. And the chapter I was working on, I'm not kidding, this is not an exaggeration, that week when she came by, the chapter I was working on, the title is Recognizing the Many Different Faces of Depression. I completely missed this. And she joked with me about it, and I saw it. Now, since that day, I've had moments where I've underestimated my need for treatment. But for the most part, I've never, ever unlearned. I have not, since that day, forgotten that I am somebody who is vulnerable to episodes of clinical depression. I am. I don't like it. I used to never talk about it. I don't feel that comfortable talking about it even now to all of you, and I know this is a very supportive, welcoming audience. So it's still not easy for me. It still is embarrassing. It still makes me feel weak. I always get a little scared when there's a videotape. What prosecutor is going to see this in some case I'm testifying on and do some bizarre thing with it, So the stigma is still there. The anxiety about the diagnosis is still there, but you know what? I'm aware. That's the difference between denial, at least for me, it's a very real difference between denial and what I saw in my brother, who could never, ever seem to lower what I thought were defenses, or these guys in that last study. They broke through the unawareness, their lack of awareness of their movement disorder, and yet it didn't stick. 2 weeks later, they'd forgotten. So all these things are making me wonder. I'm going to come back to the data that indicates that this is really, more often than not, this lack of awareness that's severe is really a function of frontal lobe pathology. And probably other aspects of brain function are involved as well, but not surprisingly, the frontal lobes play a large role. Before I do, I'm going to summarize, though, some other research. Not surprisingly, noncompliance with treatment and services is much greater in someone who doesn't believe they're ill. Why would I go to a day program if I didn't think I was ill? Right? And I'm summarizing well over 200 studies now over the last 10 years. There was an explosion of research in the 90s. There was really only a handful, about 4 empirical studies prior to 1990. Now there are over 200, the last time I counted. It's really been a remarkable change. You couldn't get a grant to study this back in 91. Now you can. I've had several, and I know lots of people who have had more than several. But not surprisingly, if you don't think you're ill, you're not going to participate in any of the treatments or services. It's not entirely true, but that's what most of the research finds. Involuntary commitment is greater, poorer course of illness, and that's been researched in a lot of different ways. Number of hospitalizations, number of episodes, quality of life measures, quality of social relationships, work. You look at quality of life and also measures of the illness itself, and things go worse for people who do not understand they're ill, who persist in that. It's not really surprising to any of us, is it? Why this would really make things go poorly for the person. You take just the example of my brother, which I can't escape because it's the most important instance of unawareness in my life, and just when we were fighting so much about it, he was in and out of the hospital 5 or 6 times a year, but then he also was disappearing and going hitchhiking and leaving. Because every interaction he had with me or anybody else in our family quickly turned into this battle, this fight, where I was telling him he was sick and he was telling me I was crazy. The psychiatrist all brainwashed you, Javi. That's when he was being kind. Usually he was really angry. So it's not surprising. Criminalization of people with mental illness as well. You do see, and there are just far less research in this area, but there are some studies now that indicate that those people who end up in the criminal justice system, like a Ted Kaczynski or a Margaret Mary Ray, who never hurt anybody but was trespassing, are far more likely to be in that group who don't understand they're ill. That makes sense, doesn't it? That the people who end up doing do you have dine and dash? Do you call it that here? No? It's a terrible name that the prosecutors call it dine and dash, but basically somebody sits down, has a meal, and then they leave without paying. Well, you can imagine somebody who's disorganized with mental illness is prone to doing that, and not because they're dishonest or trying to break the law. So you see a lot of those kinds of arrests and convictions, misdemeanor convictions. Well, awareness of being ill, of having one of these illnesses, is among the top 2 predictors of who will take medicine. Big surprise. But what's the other big predictor, do you think, of who will take medicine? Anyone? I'm sorry? Support. What kind of support? I was very supportive of my brother. What are you talking about? I was there for him. I personally called the police on him at least a dozen times. That was too supportive. Why do you think I did that because I didn't like him? I did that because I loved him and I was scared for him. I know you know what you want to say, so say it. But I'm making a point. It's not any kind of support. What kind of support? Can you characterize it? Not blaming. That's an important piece. You're right. How do we get to the point where we're not blaming somebody for their lack of insight? I like that. Carl Rogers. Unconditional positive regard. I mean, I think you're absolutely 100% right. But how do we even get to that point? Because remember, back when my brother first became ill, I was hurt. I was angry, but underneath that I was hurt. I was disappointed. This is the man who taught me how to be a man in many ways. And he's a good man, and he's an insightful person, he's a humble person, and I was hurt and angry that he was not taking responsibility. Henry, take responsibility, God damn it, pardon me. I can go there in a second, those arguments, at 2 in the morning when he was terrifying our mother. Why aren't you doing what I've seen you take these pills and you're better. So how do you stop doing that? How do I stop? How does any one of us stop being so angry? Or if it's not anger, so accusatory? Absolutely. It's understanding that this is not the person's fault, which is where you started out. Okay? So what does that look like? Well, what it looks like is a relationship where you're respecting that person's point of view. So that sounds easy, doesn't it? It's 2 in the morning. My brother just jumped into the swimming pool. He's come in the house. He's woken up my mom, accused her of being the devil and killing him with laser beams. And she's terrified, calls me. I come to the house. I'm supposed to respect his point of view about what? He needs to go to the hospital right now. That was my point of view. It's not so easy. It actually is far easier than it would seem. And by the way, I am going to take a break in about a half an hour, and then we're going to talk about how I would do that and how you could do that, and how there is some evidence base or research that shows us methods for engaging somebody in such a way that we can respect their point of view while keeping them safe. But respecting the point of view of the person with the illness is key, especially their point of view that there's nothing wrong with them. That person feels that they can trust you because you listen to them without telling them they're wrong, without telling them they're mentally ill. And in this relationship, you're somebody who believes they'd benefit from treatment. Those are the 3 characteristics. If you look at the research on what works, that's what I parcel out from the research, that there are these 3 characteristics to the relationships or the social support, as you put it earlier, that are key to getting somebody in treatment, even when they don't think they're ill. Even when they don't think they're ill. Okay, you all with me so far? Any questions before I? This is a weird one, and I was surprised by this. The research that we've done and other people have done, where you really have large numbers of people so that you have good statistical power, where you have reliable and valid assessments of symptoms and insight, we find that insight is not associated with symptoms getting better. It's kind of weird when you think about it, because I can tell you, I've written in many medical charts in many hospitals, upon discharge, insight improved. Right? How many of you have written that in a chart? We often see that the person is saying, I acknowledge I have an illness, and yes, I'm going to take the medicine. My brother did this many, many times. Many times. Early on, back in the days when you actually used to have family meetings in hospitals. We don't in the U.S. very often anymore because people are only there for like 3 days. But I can remember going to these family meetings, and my brother saw the light, Sort of like he had come to Jesus. I get it. I'm mentally ill. I understand. I will take that medicine. I want to go to that day program. Can I go today? I mean, I'm overstating it a little bit, but not by much. He'd come home, and he would do nothing, which, of course, would start that little denial dance again where I would confront him, and he would get mad, and, it got him nowhere. It got me nowhere. So what was I seeing? Why was he telling me this? And why do many people, when their symptoms get better, often make statements like my brother did? That's what the research suggests. That's certainly what my clinical experience has shown me. Over and over and over again, you have people with a long history of not believing they're ill, suddenly seeing the light when they've been locked up in a hospital. So what are we seeing? A bunch of dishonest, immoral people willing to lie? Is that what we're seeing? No, then what? And they're happy with where they're at. Okay. Right. But have you ever been in that situation where, let's say, you ended up in a hospital and you didn't think anything was wrong with you, and you found yourself saying, yes, there's something wrong? Probably not. I mean, it sounds like because you're saying my mental illness, so you already have insight. So we're really not talking about somebody who has that gift, frankly, of understanding that you have difficulties. We're talking about somebody who doesn't. So my question was, are we dealing with a bunch of people who are just dishonest and immoral? Are we? My brother lied to me. I mean, do you know how upset I got with him about this? I'm a pretty nice guy, actually. I'm not as terrible as I sound. But I do remember feeling so angry and hurt. Because it's frustrating day after week after month after year, this battle. It's draining. Well, I don't think... Did you want to say something? Why would somebody say something that's not true like that? Sure, that's possible that it has something to do with changes in neurochemistry and so on, but I think the answer is actually a lot simpler. And let's erase that division between, those of us with mental illness and those without, or with this kind of mental illness or that. He was being a smart human being. He was exercising a lot of common sense. Any one of you in this room, were you locked up in a hospital, right? Either against your will or you were coerced, you were pushed into it by your family and friends. Any one of you would lie, I'm sure. Or at least it wouldn't be so far-fetched to imagine you might lie. And why might you do that? To get out. To get your freedom, right? I mean, I don't mean to belabor the point, but again, we lose sight of this person's perspective so easily. Right? You're locked up in the hospital against your will. You don't really want to be there. And what are you going to say to get out? Everything and anything that they want to hear. Yes? I lost the last part of what you said. Who was going off medication? You were, okay. And he or she? Accused you of something. I lost you, I'm sorry. So the accusation was true? Mm-hmm. And your question? You lost it? Okay. If you remember it, come back to it, all right? How many of the women in this room think women have better insight? Yes. This has been studied thoroughly, credibly, and authoritatively, and I can tell you, I will stake my professional reputation on it, there is no credible evidence that you have better insight than men when it comes to awareness of mental illness. Sorry. There's a couple of very, very good studies with large numbers of subjects with, trust me on this. But I'm going to you may be more apt, and there is social psych literature on this, to seek help than men. And it has more to do with the nature of this problem and these disorders and the brain dysfunction, I think. But I'm going to make you feel better. There was a nurse I met who works in OBGYN who told me that apparently at birth there is an immediate test of intelligence. Did you know this? At birth. The babies, the smart ones, when they're born, the smart ones, not the rest, the smart ones. When you spank their bottoms, hold them upside down and spank the bottoms, on all the smart ones, the penis falls off. You don't get it, do you? It's a guy back here going, wait, what? The penis, that's bizarre. What's with that? Now, one is anecdotal, and one is, never mind. I'll let that issue lie for now. So what causes poor insight? Well, when we started our research in this area, we considered a few possibilities. One, of course, is this is psychological defense. There's been a lot of studies of this. We've done studies of this. We've looked at experience of stigma. We've looked at trait-related personality measures, ways of looking at whether somebody is sort of inherently a defensive person or not. And those things do not predict very much of what we're seeing when somebody says, who has mental illness, when that person says, I'm not sick, there's nothing wrong with me, and they say it for weeks, months, and years, despite all this evidence. This is not a big part of the picture. People with serious mental illness are people get defensive. So being defensive is a part of the picture. It's just not explaining much of what we're seeing when we see this very severe lack of awareness. Cultural differences also play a small role, understandably. So what my brother used to call his philosophical nature, the doctors called thought disorder. That's a cultural difference, right? Now, with education and so on, and sort of parsing that out, you would hope that he would come to see that he also had thought disorder in addition to being a philosophical thinker. But he never did. But cultural differences do make, and I'm talking about the larger cultural differences as well, obviously, between ethnic and religious cultural differences. But we also considered neuropsychological deficits. And the reason for that is that I had worked in a neurological unit doing assessments for a year at a hospital and met a lot of people with anosognosia and found that people with neurological deficits following brain injury who had this severe lack of insight looked very, very similar to the many people with schizophrenia and bipolar disorder, etc., that I had met. They looked very similar to my brother. And how were they similar? Well, first of all, it's a very, very severe lack of awareness. And I'll give you an example. There's a guy that I evaluated who, following a stroke that affected the frontal lobes of his brain, was, in addition to other areas, was paralyzed on the left side of his body. I knew he was paralyzed, but I asked him, as part of the evaluation, can you move your left arm? And he said, sure, no problem. Yes. So I asked him to move it. And of course, it doesn't move because the motor areas in his brain have been injured. And I asked him what happened. He said, well, I moved it. I said, well, no, you didn't, actually. He said, well, yes, I did. Rather than argue, I said, tell you what, maybe, why don't you look at it this time? So he turns his head, looks at his arm. I ask him to move it. He doesn't move it. I asked him what happened. And he hemmed and hawed and hesitated, and then he said, no, I don't really feel like it. Because now he saw with his own two eyes he had not moved it. I pleaded with him. I was a student at the time. I said, look, I've got to finish this. Just, do me a favor and just try one more time for me. He said, all right, all right. He doesn't move it. I asked him what happened. He doesn't want to tell me. And then finally, after some convincing and reassurance, he says to me, I don't want to tell you this because it sounds crazy, but I think you tied it down. You did something to it. So a very severe lack of awareness, wouldn't you say? And it's a lack of awareness that he's paralyzed that persisted despite evidence. I showed him, I proved to him, didn't I, that he's paralyzed? If that happened to you, wouldn't you wonder if maybe you were paralyzed, in fact? Or at least in that moment, unable to move your arm. But we also saw what are called confabulations. These sort of unreasonable, or illogical, rather, explanations. What were his confabulations? The most strange one was that I had tied his arm down. He actually gave us two others. The first one was, I moved it. That's a confabulation. He didn't move it. And yet, for a moment, he believed he had. He's not lying to me. When I asked him to look the first time, he said what? What was his confabulation then? I don't really feel like it. Right? Which sounded a lot like my brother. It sounded a lot like many people I've worked with over the years. Why did you come to the hospital?